So in doubt clearing session, my responsibility is to present on echocardiographic findings of acute aortic dissection. The title goes like this: acute chest pain. Is what I am seeing an intimal flap? What to do next? So my patient is a 55 years old male with past history of hypertension for last 5 years, came to us with sudden severe anterior chest pain with extension to the back of the chest while playing golf. Pain was tearing in nature. On examination, we found pulse 90 beat per minute regular, BP was 150 by 90 millimeter of mercury. He was quite stable. ECG showed non-specific ST-TUF changes. In echocardiography, I could see normal-sized cardiac chambers with no regional wall motion abnormalities, good biventricular systolic function, no pericardial effusion. But while doing the parasternal long axis view, I could see a dilated aortic root and an echo-dense linear structure inside the aortic root moving up and down. Is this a dissection flap? Or is it a reverberation artifact? This assessment of this echo-dense linear structure in the aorta is always a major challenge and a problem for transthoracic echocardiography because there is limited diagnostic accuracy of transthoracic echo. When the patient comes with chest pain in the emergency room, patient is most of the time lying flat on the bed. We cannot turn the patient to the left lateral position. Window is not good, machine may not be very good, and which all results in poor quality of the image and possibility of frequent diagnostic error. And moreover, this type of linear artifacts are very common in the aortic root, more so when the aortic root is dilated. And at times it becomes very difficult to distinguish those linear artifacts from the intimal flap. So what do I do next? Should I report it as an artifact and no further workup? Or should I report it as an intimal flap and dissection of aorta and go for transesophageal echo, cardiac CT, cardiac MRI, chest X-ray, or even cardiac catheterization? I thought, let me use color flow in my transthoracic echo to increase the sensitivity and specificity of transthoracic echo. With color flow, I could see the entire flow is going in the aorta above the echo-dense linear structure and in the parasternal long axis. And in apical 5-chamber view, I could see a small aortic regurgitation. And in the suprasternal view, I could see the flow in the ascending aorta and the descending thoracic aorta also. But I'm still not sure about the diagnosis. I didn't get any clue even after using the color flow. But I have a very high suspicion of dissection. And I cannot rule out the diagnosis of dissection because there is low negative predictive value of transthoracic echo. It doesn't permit me to rule out the dissection. So the guideline says you go immediately for the second imaging modality because key to success in treating acute aortic dissection is prompt diagnosis, as 40% of the acute dissection patients die immediately. And those who survive, they carry an added mortality of 1 to 2% per hour, which is very high. So we go for the second line of imaging modalities, which are transesophageal echo, cardiac CT, and cardiac MRI. The recent meta-analysis has shown that all these three imaging modalities have high equal sensitivity. However, CT has a better specificity than transesophageal echo and cardiac MRI. Each test has its inherent advantage and disadvantage. And the choice depends on the availability of the test. But in cases of suspected acute aortic dissection, while proceeding for the diagnostic workup, we should also initiate the consultation with cardiothoracic surgeon, and we should stabilize the patient in the ICU. And while doing the transesophageal echo, utmost care should be taken by monitoring the heart rate, blood pressure, and the oxygen saturation. We should maintain a low blood pressure while doing the transesophageal echo, because high blood pressure will cause further propagation of the dissection of the aorta, and T should be done under careful conscious sedation. The aim of the doing conscious sedation is to get maximum cooperation of the patient with minimal agitation from the patient. So as we do the transesophageal echo, we can demonstrate the intimal flap in the aorta, which is the hallmark of the diagnosis. In aortic dissection, there is a tear in the intimal flap through which the blood enters, and it separates the intima from the media and the adventitia, and the intima moves freely in the aorta, and it looks like a worm wiggling in the aorta. As is seen here, this is the mid-esophageal aortic long axis view. This is the aortic valve, left ventricle, and this is with the color flow. If we look at this intimal flap, this is moving freely in the aorta. It has distinct borders. It is undulating with the cardiac cycle, and it has got a greater longitudinal extension. The picture is much more clear than we got in transthoracic echo. Now, as the blood flows through the tear, it forms a false lumen between the intima and the media, forming a true lumen and a false lumen. The true lumen is usually small, as is seen in the center. On the either side is the false lumen. The blood is moving into the true lumen with each systole, whereas in the false lumen there is blood, but if you see carefully, it is continuous. The blood, there is stasis of the blood, whereas this blood is pulsatile. So this is the true lumen, and the flap moves towards the false lumen during each systole, and the false lumen is usually larger in size. It is also necessary to identify the entry tear from the true to the false lumen, because the principal aim of surgery in type A dissection is to obliterate the entry tear in the ascending aorta, as is seen in this long axis view in mid-esophagus. If you see this dissection flap, there is a tear here, the blood is entering, and there is a smoky appearance here, and the true lumen is showing pulsatile flow in the aorta. The entry tear occurs at the site of the greatest wall stress, and in 65% cases, it is within the 3 centimeter of coronary ostia. It is also necessary to visualize the coronary arteries, which can be done very easily with transesophageal echo, because in 10 to 20% cases, the intimal flap propagates to the origin of one or both coronary arteries. This is the mid-esophageal aortic short axis view. The left coronary artery is arising from the left coronary sinus, and the right coronary artery is arising from the right coronary sinus. This is the patient with the aortic dissection. As you can see the intimal flap, this is the true lumen, this is false lumen. The left coronary artery is arising from the true lumen, and I had a doubt about the origin of the right coronary artery, but somehow I could see in one of the view, I could see that it's arising from the true lumen, and moreover, I didn't get any wall motion abnormality in transesophageal as well as in transthoracic echo. So the visualization of the coronary arteries can be very easily done by transesophageal echo. It is also critical to give the information about the severity and the mechanism of air to the surgeon because it influences the surgical decision. If you look at the mechanism of the air in aortic dissection, these are due to acute dilatation of the root, disruption of the commissures, prolapse of the dissection flap, as is happening here, or there might be pre-existing aortic valve or root disease. So in the first three cases, surgeon can repair the valve, but in the last case, surgeon has to replace the valve. So it is necessary to provide the information about the mechanism of air also. Here the transthoracic echo has got a big role. We should measure the aorta starting from the annulus to the ascending aorta. Pericardial effusion should be excluded because it is a sign of poor prognosis. Thus we see we can give all the informations like identification of the tear, entry tear, assessment of the air, visualization of the coronary arteries, etc. to the surgeon other than involvement of the head and neck branches. Most of the cases in transesophageal echo, it is not possible because of the blind spot we face while doing transesophageal echo in the distal ascending aorta and the proximal arch, because the trachea passes in between the aorta and the esophagus where our probe is. So it hinders this transesophageal echo image to come in this part of the aorta. It is very difficult to image first and the second branch. Here we need the help of cardiac CT where it can easily show the involvement of the branches of the arch. As is seen here, the first branch is involved. This is the true lumen. The first branch of the arch is involved. So this is the strategy we follow usually when there is stable patient. But that may not be possible in many cases, as occurred in this patient. A 26 years old lady with 30 weeks of pregnancy came with sudden severe epigastric pain. ECG was normal, USG was normal for 30 weeks fetus. She was getting treatment for 4 hours for acute gastritis, ultimately referred to a cardiologist. And when I did the echo, I found the patient orthopnic, pulse 120 beat per minute, BP 90/50. And in echocardiography, in transthoracic echocardiography, which I did, patient was sitting on the stretcher and I did the echo. I could see the intimal flap, which was causing the air because it was getting prolapsed through the aortic valve. The valve was normal. The true lumen and the false lumen could be easily seen. I could visualize the coronary arteries, and I could see that there is no wall motion abnormality in the heart. So, and I could also visualize the extent of the dissection up to the second branch from the suprasternal view. As you can see, this is the true lumen and this is the false lumen. The dissection flap is extending up to the second branch. So this is a patient who is having high risk category with pregnancy. We have no time for transesophageal echo. We cannot go for CT also because she is pregnant. So what we did, we utilized the transthoracic echo findings to initiate the prompt surgical consultation. We gave a call, emergency call to the cardiac surgeon, and we allowed the patient to undergo the surgery. Now my question is, can we allow the patient to go for surgery only with transthoracic echo findings? Thank you.
I think in the second case you mentioned we don't have much choice, and you got very good images in which you could diagnose the extent of the dissection.
Yes, I could show all the informations. I could give all the information to the cardiac surgeon. Other than the few minute things like, though I could see the neck vessels also. So most of the informations
And
were available.
for
in the-
looking at the neck vessels, we can do a carotid Doppler study. It is not a
There was
big
no
deal.
time, sir. No, there was
Okay.
no
The
time.
time was an
Patient
issue.
was orthopnic, deteriorating very fast. We took the patient to the OT.
Okay.
So
I
is
hope
it
she
allowed?
survived.
Like, is it allowed?
No, in an emergency, everything is allowed.
Yes.
In such an emergency, if the patient is crashing, everything is allowed. Then you don't
So,
have to go
yes.
into such soul searching.
So strategy depends on the category of the patient. The
Certainly,
Yeah, clinical risk of the patient, whether it's high risk. Yes, but it has. Yes, but transthoracic echo has many problems. Like sometimes it may give wrong informations also. So usually we don't take the patients, but this is a scenario where we had no choice.
So,
we had to go.
so perhaps Dr. Devika, can you enlighten us about how to differentiate between artifact and the intimal flap? You
Yeah, the
suggested that it could have been an artifact in
Yes.
your first case.
Yes, the artifacts. Yeah, the intimal flap undulates with the cardiac cycle. That is the typical description, and this undulation is more prominent in the acute dissection. As it becomes chronic, the movement may be a little less on the lesser side, but in acute dissection, we always see the undulation of the intimal flap, and it has got a longer longitudinal extension in the aorta, and the artifacts are static usually. These are the differentiating points.
Either the artifacts are static or they follow the motion of other structures. If they are duplication artifacts, they can exactly mimic the motion of other structures. So that should give you a clue. And then changing the angle of your probe, changing the view, can also help you differentiate. So if you're
Yes.
seeing a particular
You should go one space above.
one space
sometimes,
above,
yes.
or if you're seeing something in a parallel long axis view which you suspect to be an intimal flap, then you take a short axis view at that same level. See if it is still there. Look at the color Doppler as you have done in your case. So all these things should give you a reasonably good idea as to whether that is an artifact or it is an actual intimal flap which you are seeing.
Yeah.
Because emergency, the MRI is not.
We couldn't take the patient, sir. Patient was orthopnic, BP was falling, she was tachycardic, heavily she was sweating, and she was restless. We couldn't take her.
So
What extra information were you looking for? You were off.
Yes. And
You were not really looking for anything.
so the message is, if the transthoracic echo is of very good quality, we can take the information.
But it's also with clinical correlation.
Clinical, along with the clinical correlation. It was an unusual presentation for a pregnant lady, though this is the commonest, this acute aortic dissection is common in pregnancy because of the increased cardiac output.
Another important pregnancy is important is leading factors for disease.
Yes, yes. Yeah. It happens in the mid trimester of the pregnancy.
Can there be anything else other than the dissecting flap? Can there be any human like Parkinson? Can there be anything other than the flap or the artifact? Can there be human like Parkinson and others?
Fibroelastoma where, sir? In aorta or in the valves?
Yeah.
In the cardiac valves.
The intimal flap that might have mimics the fibroelastoma of the aortic valve.
So I think a closed DD of this dissection is the intramural hematoma.
Yes,
That-
intramural hematoma
that is
is
a closed
yeah.
DD. Now
Yes.
for the PGTs, actually this often happens, the overdiagnosis of dissection is made from transthoracic echo. I am
Yes.
actually from the post-peritoneal.
Yeah.
The issue is, as Madam said, the reverberation effects actually. When you are doing a transthoracic echo, in the ascending aorta, first part, there will be a reverberation effects of the left atrium anterior. And when you are going off, say for ascending out a mid part, there will be the reverberation effects of the pulmonary artery posterior. So these two things you should remember. And as I said, the differential point of the reverberation effects that you should look for.
There was a mild aortic regurgitation in that pregnant lady because of the prolapse of the dissection flap. Yes.
So in the second case, it was
Very
classic.
clear,
Yeah,
very
it
clear.
was
We
very-
don't have problem in those
Right.
cases.
The first
But the
case,
first-
it also suggested, right? I mean, the clinical story was so classic. He was playing
Yeah, she was
golf,
playing, he
severe
was
chest
playing,
pain
yes,
and tearing. I'll address a few points. Sorry. So the MRI suite is a terrible place for an unstable patient. You can't resuscitate people there. So generally, you don't take sick patients to
To the MRI,
right?
yeah.
One of the things you could do is move the patient to the OR and put a transesophageal probe while she's in getting intubated and all those things. You can
That's
get
what we did in the pregnant lady. In the
Right.
OT, once she was under anesthesia, we introduced the
that.
probe.
That would give you a lot more information.
Yeah.
The only information you couldn't get is the extent of dissection, whether the renal artery is involved or
Exactly.
something else is involved.
Those-
But you can address that after the patient is alive. If the patient is dead, then
Once
there's
the
no
patient-
point in getting that information. Has anybody had experience giving contrast echo? Definity or any of the perfluorine agents to
Yeah.
see whether
There is a role of contrast echo.
sometimes that
yes.
helps you because a lot of that stays in the
Dr.
in the-
Nanda has written a book.
yeah,
I've
and then you
seen
start
it.
getting shadowing in the false
Yes,
lumen.
yes.
So sometimes
But
that helps.
we don't use it.
Yeah, but it takes a second or two to just inject. So you might want to do that if you have a doubt.
Yeah.
But just to highlight, as I'm told there are many students here, just to highlight that not all dissections present with these classical symptoms of a tearing pain and so on. Some of them can present with very atypical symptoms. I have a case where there was an acute dissection. She presented with a stroke. And a stroke can of course occur because of extension of the dissection into the carotid arteries, but also because of maybe a spontaneous embolization of a small thrombus or something like that. And that patient unfortunately we lost because not only did she have present with a stroke which delayed the diagnosis of the dissection, but also by the time she came to a cardiologist for an echo, she was in tamponade. There had obviously been at least a partial rupture somewhere of the aorta. She was in severe tamponade. Before she could be taken up for surgery, the lady passed away. So for students, it's wise to remember that in every case, you may not get the typical symptoms that are described in the
Yes,
textbooks.
What did the surgeon think was the mechanism of AI in the first case? There was mild AI, right?
Yes. It was probably because of the lack of support of the commissures.
But the sinuses didn't look very dilated.
Sinus was dilated.
How old was that patient?
45.
For,
A little young to have
Yeah.
sclerosis of the valve.
but air was so mild,
Yeah.
they didn't replace it.
Just one comment, I think again for the juniors here, that when you are suspecting a dissection, you can start from the ascending aorta and then go up to the arch, but make it a point to also take a clear look at the abdominal aorta, finish with that.
Yes.
That is something which has to be, as a routine, it's like a loop, you have to close it at that point.
And it is so easy to see the false lumen and the true lumen in the abdominal aorta.
And you
Yes.
also get to know the,
Yes.
if it's a
Yes.
type A, type B, I mean.
Type A
etc.
and type B.